Well, the guy out there? Yeah. Nobody else came in. I think we just go. Good morning. Can you guys hear us okay? Okay, I think we're going to go ahead and get started. In the program, I think there's a wrong title, so just to make sure you're in the right place, we're talking about our research. We have an RRTC, Aging with a Physical Disability, and we're going to talk about the lessons we've learned from that 5-year grant. And my name is Aimee Verrall, and this is...
I'm Alex Terrill, and we're from the University of Washington, Department of Rehab Medicine.
So I'm actually the research manager for the RRTC, and I have my MPH, and that's a Master's of Public Health, so I'm kind of a public health. I'm going to do this. How? Is this better? Okay. All right. Good. So I have my MPH, and that's a Master's of Public Health, and so I'm a more public health person, and I'm going to let Alex introduce herself.
So I'm currently a postdoctoral fellow at the University of Washington, and my specialty is in rehabilitation psychology.
So to start off with, we want to just thank our entire research team at the University of Washington. We're in the Department of Rehab Medicine. We got a great team with a lot of research assistants and coordinators and postdocs and lovely group to work with. We also want to thank our advisory board who help us solve problems and advise us on how to do certain things. And last but not least, we especially want to thank our research participants, because volunteering in research, we couldn't do any of what we do without volunteers. So, what is an RRTC? So we are really honored to be funded by the National Institute of Disability and Rehabilitation Research, or what we call NIDR. And NIDR funds these big center grants, which they call RRTCs, and they have many all over the U.S., and they're typically at academic institutions, and each one focuses on different things. So there's one that focuses on employment for people with disabilities. There's one that focuses on rural health care, and there's one that focuses just on health and function of people with developmental disabilities. So our RRTC focuses on aging with a physical disability. We've had one the last 5 years, and we were really, really lucky to just get funded with another one so we can continue our work. And it's also on aging with a physical disability, and it's a more kind of healthy aging. SLANT is our new one. And then we have this very threefold mission where we do research studies, and we do training activities, and we try to be a resource center. So what are these core mission areas? So our research studies, instead of, a lot of research just is funded to do one research study, but we're really lucky that the RRTCs get to do 3 to 4 different projects. So we do a lot of surveys, and we get to test like behavioral interventions, and we get to do a lot of things with measurement. And then our training projects is Is it on again? Okay. Lost the mic. So our training projects is a unique thing that in other research studies that I've worked on, this doesn't normally get funded, but we get funded to train new educators and new researchers and healthcare providers, and we get to tell them about what is aging with a physical disability, so that hopefully out there in the field there'll be more physical therapists that know what it is to be aging with a physical disability. And then we get to be a resource center. So we get to disseminate our findings, we get to share it with people, we get to go do lovely presentations like this one. We get to answer questions, and we get to try to connect people with resources. And I'm going to pass it off to Alex.
So to give you an overview of what our presentation today is going to cover, we're first going to talk about our survey. We'll introduce it, tell you who participates in our surveys. We'll define what we mean by healthy aging, and we'll really talk about 3 particular components: physical, social, and psychological. And this is where we'll present a lot of our research findings. Finally, we'll kind of give you a preview of things to come, so things we're looking forward to in our next cycle of the grant. So who participates? Let's start by talking about our survey, and I suspect that to many of you, this will look really familiar. But how did we figure out what kinds of questions to ask? Well, really good researchers know or can admit when they don't know the answer. And for this reason, we go to what we call focus groups. Focus groups are groups of 8 to 10 participants. In this case, it was people with long-term physical disabilities associated with post-polio syndrome, spinal cord injury, muscular dystrophy, and multiple sclerosis. And we asked them, what matters? What should we be asking about? So are there things that you noticed have changed as you've gotten older? Things we should be paying attention to? And here are some examples of what we were told.
I see my legs getting weaker and weaker, especially my left leg that I've always referred to as my good leg, because it hasn't been in the brace, and I think it's been doing all of the work.
I couldn't walk anymore. It was as simple as that. I couldn't even use crutches anymore. I fell down, and when I got up, it was the end. I couldn't drive anymore, I couldn't walk anymore, and there was only one thing to do, and that was to sit.
I do a lot of different things. They're not as physically demanding as the other things that I used to do, so it's changing your outlook toward the activities and finding a replacement that's suitable, but that you still get a lot of enjoyment from.
It took a long time for it to sink into my head why I was being told to use a cane. All my life I'd worn a brace, so why would I need a cane? It took 2 years. Then it finally was kind of like a bell went on. Conserve energy, sleep better, less pain, this vicious cycle, and finally I started to use one. So there were several things that kept coming up in these focus groups, including that symptoms like pain and fatigue tended to get worse, and they really impacted people's ability to live their lives, including their social lives. But there were also a number of ways that people were adapting and coping with some of these changes. So we knew that in our survey, we wanted to address all 3 of those areas: the physical health, the social well-being, as well as the psychological well-being.
So here's a big stack of our surveys of what they look like when they get sent back to us, and maybe they look a little familiar. And for those of you who haven't done our surveys, they're big. They're 44 pages. So over the last 5 years, we've had 6,000 surveys filled out, millions of questions answered, and our research staff has done thousands of phone calls to collect missing data and make sure our surveys are sent back. So over the last 5 years, we've done 4 surveys, and the first and the 4th survey, our entire group of folks participating have sent in surveys. In the middle years, there was an age restriction, so only people 45 to 65 years participated. And now we're going to just take a closer look at just who participates in our survey. So from all over the nation. So we have a big West Coast presence, because that's where we're from, in Seattle. But you can the darker colors are more people, the lighter colors are less people. But also a big following in Texas, a big New England presence, Florida, and then kind of a big presence right here in St. Louis, in this area. So we have 4 different groups of people that participate in our survey. The largest is multiple sclerosis, just under 600, and then spinal cord injury with just under 500. And then people with post-polio syndrome, just a little, about 450. And then folks with muscular dystrophy. And this is just all our 4 groups looking at by age groups. So the darker ages are, darker green is younger and lighter is older. You can see there's quite a difference. Like our participants with post-polio are much different age distribution than our other groups. Oldest. This is looking at it by gender. So Alex is going to take this one over. We're switching.
So overall, we had many more women participating in our survey than men. And for conditions like multiple sclerosis, that's just the nature of the condition, that you just have more women with MS than men. For post-polio syndrome, that's not necessarily the case, but we did have many more women participating in our survey than men. We're not entirely sure why this was happening in our survey.
We sort of know that women like to participate in things sometimes a little bit more than men. And this is by mobility level. So there was one question on our survey that had people rate sort of how far they could walk and what kind of assistive devices they use. So none or mild in this case is using relatively little assistive devices. Severe and extreme are using more wheeled mobility or power chairs, and then in the middle is assisted devices like walkers and canes and braces and things like that. So you can see it's pretty different for each of our groups. So, and post-polio looks a little bit more like our folks with spinal cord injury with a lot of more wheeled assistive device use. So in our year 1 survey, we asked a lot of questions about each diagnosis. And for people with post-polio, we asked a lot about your experience with your initial polio episode. So we asked, how severe was your initial polio? And so here's how folks answered. Very severe, mostly moderately severe, and very severe is what people reported. Okay. We also asked, how long did your initial polio episode last? And most people said over a year. And then all the other time frames were about equally distributed there. We asked how old you were during your initial polio episode. And you can see most people were infants, toddlers. But we do have some folks who contracted polio as an adult. We think these are folks that maybe were living outside the U.S. and then immigrated to the U.S. We asked, where did you experience weakness during your initial polio episode? And so predominantly folks said legs, then torso, arms, then other areas, lungs and head. So next, Alex is going to take over and talk about how we define healthy aging.
So as we mentioned earlier, one of the overarching goals of the Aging RRTC is to really look at how do we promote healthy aging for people with long-term physical disability. But what exactly do we mean by healthy aging? How would you define healthy aging? Any ideas? Being able to do the things that you want to do as you age, that's actually a really great definition. So before we really delve into this, defining healthy or successful aging definition here, I want to ask if any of you have heard the recent piece on NPR that asked older adults what kinds of terms or words they hated to hear. Maybe some of you, yes. So successful aging made that list. And I think rightfully so. Successful aging puts an evaluation on how someone is aging. And as one woman in the piece said, it was just one more thing she could fail at. So So we would like to acknowledge that although we will keep referring to successful aging on occasion during this presentation, really what we mean is more this healthy aging concept which we're about to define. So in traditional definitions of healthy or successful aging, this is really included or focused almost entirely on how well someone is functioning physically or how long they're living. And this really requires remaining free of chronic illness and disability. Well, that's just not realistic. We know that about 10 to 12% of the US adults over 65 nowadays would be considered to be aging successfully if it required remaining free of medical conditions or disability. Only 10 to 12%. And 65 years old really isn't all that old, and so that percentage is just going to get smaller the older people get. So it's not realistic, and it's kind of setting you up to fail at successful aging. It doesn't account for the wide range of successful accommodations and adaptations that people make in order to buffer against the declines of physical function. And it also doesn't take into account the person's perspective, which I think is a really important piece. Kind of like you were saying, what matters to you? What is important for you to be able to do as you get older? So nowadays, there are more comprehensive and inclusive definitions of healthy aging. So in addition to that physical component, these also include psychological and social components. So that now we include things like engaging in meaningful activities, being socially connected, being able to adapt to some of these aging-related changes, and general satisfaction with life are now all considered to be really important to healthy aging. So as you saw on the previous slide, there are these three components, and I would just like to take a moment to kind of look a little closer. For the physical component, we are still talking about medical conditions and how these impact physical function. But for someone who has a medical condition or a disability, what we try to do to promote healthy aging is we're trying to prevent new conditions from coming up. So hypertension or high blood pressure, diabetes, arthritis, chronic pain, things like that. And we also want to prevent new injuries, so through falls, for example. And we want to reduce the impact these have on your daily life. For the physical or the psychological component, these include things like emotional vitality, resilience, coping, and kind of avoiding negative mood states like depression. And finally, for the social component, this includes engaging in life, especially social interactions, getting out there and engaging in your environment. So to give you kind of a more concrete example, let's take Phil and Maggie. Phil is 68 years old. He was recently diagnosed with post-polio syndrome, and he is experiencing some weakness in his legs. He uses a cane to get around, but since he's retired, he really doesn't get out a whole lot. He has withdrawn somewhat, he doesn't visit much with friends or family, and his mood's really taken a dive. He's feeling pretty low. Maggie, on the other hand, is 72 years old. She also has post-polio syndrome, and she uses a wheelchair to get around. She is a seize-a-day kind of person, typically has a positive outlook. She volunteers at her local library, maybe once a week, and gets together with friends for coffee or lunch. Now, if we were to just look at that physical component, it would be awfully tempting to say that Phil is aging more successfully than Maggie. But if we take a look at all of these components, we can really see that, well, Maggie's aging really successfully herself.
Okay, so now we're going to sort of look at what we've found through our surveys, and we're going to do this through each component of sort of those healthy agings. So we're going to start off first with the physical. So for the physical component, we're going to sort of looking at preventing or reducing secondary conditions, and then we're going to look at preventing injuries. Specifically, we're going to look at falls. So what are secondary conditions?
We know that people who are living with long-term physical disability typically have conditions or problems that are associated with the disability, so they're directly caused by it, such as weakness. But there's also a host of other problems that are not directly caused by the condition or the disability, but are still related to it. We call these secondary or secondary conditions. These include things like fatigue, chronic pain, chronic infections. And these type of problems can be just as difficult to manage, if not more so, than the actual disability itself. And a lot of these are preventable.
So we also know that people are often not juggling just one of these secondary conditions, but they're often juggling many. And a lot of these things are very invisible, so their friends and family probably don't realize that they're dealing with all of these things every day. And secondary conditions was one of the main focuses of our survey of what we wanted to find out. We wanted to track these over time and really try to figure out, did they get worse with age? Was there an age that was particularly hard for people? And we're going to look at that more. So we're interested, what do you think for people with post-polio was the most common secondary condition? Anybody have ideas? If you're comfortable shouting it out. Fatigue. I hear fatigue. What do you think impacted people's lives the most? Arthritis. Fatigue. All right. I hear a lot of fatigue. So survey says, this is right from our surveys, and this is just for our folks with post-polio. This is what they reported, and let's take a little closer look at this graph so that we can understand it. So it's broken into 3 age categories. So the darker purple is younger groups, and the lighter purple is older, so 75 years or older. And then on the side here, it's each of the secondary conditions that we looked at. So trouble sleeping, depression, pain, and fatigue. And guess what? Fatigue is the big one. And for this particular set of measures that we used in our questionnaire, they had a sample of people all over the US. 20,000 people fill out these same sets of measures. So this is actually comparing what our folks with post-polio in our survey reported to this US general population, and most of them didn't have a physical disability. So you can kind of, and within the same ages. So you can kind of see that fatigue compared to peers your same age without a disability, people with post-polio reporting their fatigue was way worse. And you can kind of see it kind of got worse as you got older. Pain, depression, and trouble sleeping had a little bit of a different pattern with age. So you can kind of see the younger group worse, then it got a little bit better, and then with the older age group got worse. So there was kind of a dip right there. We also went and searched the literature. So we got some supplemental funding to do a bunch of reviews. So we went outside of our research group and searched PubMed and all these different research, and we looked at just articles that were about post-polio, and we looked at secondary conditions to see what was reported most often. And we also tried to figure out, did other people identify any patterns with age? So we located 22 articles, and we extracted a bunch of data from those articles, and fatigue, overwhelmingly, was the most commonly reported symptom. Pain followed that, and then there were a host of other things that were reported. And then every article was so different about age that we really couldn't find a one set pattern that said what happened. So I'm going to pass this back to Alex, and she's going to talk about the impact of secondary conditions.
Okay, so we weren't just interested in looking at how common some of these secondary symptoms and conditions were, but we also wanted to know, how do they relate to one another? How do they impact people's ability to live their lives? So what we did was we looked at all of our groups. So these are our 1,800 participants, and we looked at their answers to questions on secondary problems. We looked at how their answers related to one another and how they impact functioning in everyday life. And we were also interested in looking at some differences across different ages. For example, were certain problems more problematic in younger groups versus older groups, and the other way around. So this is a model that looks at the relationships of all of these things. And what we did was we grouped these responses to the secondary problems into different categories. So for example, for the physical secondary conditions, these included things like problems with vision or speech, infection. We also had a group that was the chronic medical conditions. These are in addition to the diagnoses, so the disability groups that we had. So things like heart disease, diabetes, high blood pressure, arthritis. We also had a psychosocial symptoms category, and these are things like depression, fatigue, problems with sleep, and then pain got its very own category because it was a pretty big deal. And we looked at how these things were related to each other and how they related to functioning in daily life. And not surprisingly, we found that the physical secondary conditions had a really high impact on how people were functioning in daily life. But we also found that some of these other problems, depression, fatigue, and sleep, and especially pain, also created significant problems. And in fact, pain was more problematic and had a higher impact on functioning in daily life than some of these chronic medical conditions on the side. Importantly, I think it is interesting to note that all of these things are related, so that if you have more pain, for example, you might also have more depression, more trouble sleeping, and together these might impact how well you're functioning in daily life. So if you remember Phil, we talked about him a little bit earlier. Phil was experiencing some weakness in his legs, and he was also kind of socially withdrawn and was experiencing maybe some depression. And this was impacting how well he functioned. Now, it doesn't just work in the negative way. I think it's really important to note that it can also work the other way. So if we improve one of these areas, maybe we can improve some of these other areas as well. So that if we were to help Phil with depression, maybe he would feel more like going out, maybe he would start functioning a little better in everyday life. Or maybe it's not that he's depressed or that he's not going out because he's depressed, but he's not going outside because he doesn't feel safe. He's afraid of falling. And so maybe if we help him with a different assistive device that will help him make him feel more secure going outside, less worried about falling, now he's able to get outside more and see his friends, and his depression might improve. As I'd mentioned, we were also interested in looking at how things change with age, and older age was related to having more of those chronic medical problems like high blood pressure, diabetes, arthritis. That's on that graph right there. There were also more of those physical secondary conditions like more weakness, more trouble with vision or speech, and there were more problems in daily functioning. But it's not just an uphill battle. And in fact, some of these symptoms and conditions like the fatigue, trouble with sleeping, depression, and pain seem to be worse in middle age. And then some of these improved or remained the same with older age. Okay, so Aimee's going to talk about preventing new injuries.
Okay, so we're still in that physical component of the healthy aging 3 components, but we're just going to talk about preventing new injuries and falls. So we asked about falls in our survey. We asked the question, have you fallen in the last 6 months? And so this is what we found. People with MD fell the most, but folks with post-polio syndrome are right behind those guys, then MS, and then spinal cord injury. And these rates are all higher compared to older adults who don't have a physical disability. And so we looked a little bit closer at the rates that people were reporting falling, and we looked at them by age as well as like that mobility level. And that's that question on our survey that we talked about before, where none or mild is using relatively few assistive devices, severe and extreme are using more wheeled assisted devices or power mobility, and in the middle is more folks that are using canes and braces and crutches to get around. And you can really see everything kind of peaks in those middle mobility categories. And when you take just a little closer look at those, you can kind of see even the younger folks that are 18 to 44 are still at risk of falling and are at higher risk than some of the age groups. And we think maybe people get smarter as they get older. They get a little more careful, or if they've fallen once, then they are more careful. But yeah, interesting patterns. And this is everybody in our survey, so all 4 groups represented. And then we did some higher level statistical modeling, fancy stuff, and we looked at each group separately. And so for folks with post-polio syndrome, we looked at different risk factors to see what predicted that people would fall the most, or what would predict that people said they would fall on that question. So it was older age, and it was those middle mobility categories. And then for folks with post-polio, it was vision, and vision was the only reported in this analysis with folks with post-polio. So that was different. The other groups vision wasn't as important, but all right, we're going to move on to the social component of healthy aging, and I'm going to pass this off to Alex.
Okay, so when we talk about that social component, what we're really talking about is support from your friends, from your family and partners, as well as your social place in the world. Now, why is social support important for your health and well-being? Do you have any thoughts? We're not designed to be by ourselves. No man is an island, no woman either, right? So absolutely, we know that there's several things that we do know. As people get older, their social networks tend to get smaller. This is likely because there are many changes associated with getting older. For example, if you retire, maybe now you don't have as contact as often with the people that you used to work with. But those relationships that you do have tend to get deeper. Social support really helps in coping and dealing with chronic medical conditions, and it also helps with just daily stressors, everyday stress. And feeling supported really allows us to fully engage in life.
So we did have some social support questions on our survey, and this is looking at the results of some of those. And this is specifically for our participants with post-polio. And we looked at this by gender and by age, and you can see folks are reporting really high levels of social support. Like 7 is the highest, and these averages are all above 5. So folks with post-polio are doing really well. Typically in our other groups, we have found that there's usually a difference between men and women, that men usually are reporting lower levels of social support, and particularly for the friends kind of group. Because this particular measure kind of has an overall score that's overall, and then they look at partners and spouses, and then they look at family, and then they look at friends. And let's see, we've also found in some of our research that social support is really related to depression. So high levels of social support usually are reporting lower levels of depression. But we don't know causality, we don't know how one is affecting the other, so. And this is looking at a different question, and it's kind of like those other questions where we're comparing reports in our survey versus this other general US population that typically doesn't have a physical disability. And this is looking at participants just with post-polio syndrome. And this is questions about how satisfied am I with my social place in the world? So am I happy with my social life right now? My role, my ability to be a mom, my ability to be a grandparent, my ability to volunteer in my community and get out to all the valued activities that I have. And so folks with post-polio were actually reporting that they were less satisfied than peers of their same age in the US population without a disability, and that was getting slightly worse as you were getting older. So less satisfied as you age. And now Alex is going to talk about a higher level analysis here.
So, and again, we weren't just interested in looking at kind of how common some of these things were, but we were also interested in looking at how it impacts your life. So kind of stepping back, we talked about how these chronic or the secondary problems can interfere with everyday life, and they can also impact with your social life. And so one of our researchers was interested in looking at fatigue, particularly in people with post-polio, and how satisfied they were with their social place, social role in their life. And this was over the course of 4 years. So they measured fatigue and social satisfaction in year 1 and then again in year 4. And generally speaking, what was found was that as fatigue worsens over time, it has an effect on how satisfied someone is with their social life. So if you remember Maggie from earlier, she was volunteering a lot in her community, at her library. She was getting out a lot to meet up with friends, and so likely she was pretty satisfied with her social life. And perhaps she wasn't experiencing as much fatigue in that first year. But now imagine over the next 3 to 4 years, her fatigue gets worse, and it affects her ability to get out. Maybe she's just too tired, too fatigued to get out and volunteer as often as she would like. Maybe she's not getting together with her friends as often because it's just too much, it's just too exhausting. And not surprisingly, she's probably not as satisfied with her social life as her fatigue has gotten worse. So now we'll move into the last component of healthy aging, the psychological component. And typically, medicine especially, but also psychology, really focuses on negative outcomes, kind of what increases your risk of certain things. Especially in psychology, we talk a lot about depression. But I'm really excited that today I get to share some information with you that talks more about the other side of it, the positive side, what makes us resilient. And so to give you some context for this, I selected some quotes, again, from our focus groups. I don't even think about being disabled. I like to say, God took my legs and left me with great hair. She had beautiful silver hair, by the way. I am now seeing a lot of people in my age bracket that are in worse shape than I am in many ways. They walk better, but they've had way more problems than I seem to be having. I don't think they have grit. I wake up knowing I have MS. I smile and kiss my husband, grab my walker, and thank God for another wonderful day. And finally, here's one last quote that really had a big impact on me personally. It was from a woman with post-polio syndrome. And I think this really drives home the point as she was describing how she was able to maintain emotional well-being as she aged. You were used to a certain adversity. It's how you grew up. You never knew what was going to happen. After you got used to that, whether it took a year or 2 or 3 years, you were that same person again who dealt with that adversity and just continued on. And it was hearing statements like these that made me realize that in spite of, or perhaps even because of, the challenges that people aging with disability face, many of them have tremendous resilience. And that perhaps we could learn what kinds of things contributed to that resilience and use that information to help those who are struggling. I also very quickly realized that there isn't a whole lot of information out there about resilience, especially in aging and disability, but I really knew this was something worth exploring. So what is resilience? How would you define resilience? What do you think of? Keep going? Yeah. Bounce back. And that's not all that different from how we define it. It is the human capacity to persist, to bounce back from, and even thrive in the face of adversity or challenges. And it's a dynamic process. Now, resilience, typically we think of this as something we're born with, a stable trait. And yes, we are all born with some level of resilience. Some of us are born with more, some with less, but it's not written in stone. This can change over time, especially if we interact with our environment. There's certain experiences we have, things that we live through, things we learn from. And so these include coping skills, interpersonal skills that can be learned and practiced. What does resilience look like in our participants? Well, on this big graph, we look at all of the different groups and age groups. And on average, our participants with post-polio syndrome were higher in resilience than our other groups. But you can see, I kind of pulled out the smaller graph on the side there, looking at age groups, that it gets better or it increases with age, but that it's pretty low for people who are in that middle age category, the 45 to 50-year-olds. And that was something that was found across most of the other groups as well, that middle age seemed to be a difficult period, or a period where people had lower resilience. So we also looked at resilience and depression, and we found that those participants who had higher resilience were lower in depression or had no depression. And those who were lower in resilience had much higher depression. We're not entirely sure about the directionality of that. We're still looking at that. And here's a graph that ties it all together. So looking at resilience, depression across the different ages. And I think this illustrates really nicely how as resilience in that middle age group, those are the bars, is lower, depression is much higher. So really this middle age group seems to be a little bit more vulnerable perhaps as they struggle with things like having more of those secondary symptoms or conditions, and they also have lower resilience, which might put them at higher risk of things like depression and lower quality of life. And so that's kind of the question that I was interested in exploring next. Does resilience really matter? Looking at that big picture, at how these secondary conditions affect each other and everyday life and quality of life, how does resilience fit into that picture? Could it potentially buffer against effects of fatigue and pain? What about quality of life? Could it improve our quality of life? And here's again a model that looks at all of these relationships. And the short answer is yes, resilience matters quite a bit. We found that participants who were higher in resilience experienced much less depression and reported higher quality of life, even in the face of relatively high levels of pain and fatigue. So again, if we have that middle-aged group who's experiencing more of these secondary conditions and they already have lower resilience, likely they are experiencing more depression, or they're at higher risk of depression and lower quality of life. But maybe there's something we can do to increase that resilience to have an effect on quality of life, on depression. That's kind of the next step that we're working up to, figuring out what sorts of things might work to increase resilience in people who are aging with physical disability.
Okay, so now we're going to finish our presentation with where do we go from here? So we have this new grant. Now what are we going to do? So we have new funding. We have a new logo we're very excited about. We have a new website. We're going to do new research, but we're also going to continue the research that we were doing. So we're going to do more surveys. Yes. We're going to keep sharing our findings. We're going to keep trying to answer people's questions and be a resource. So what kind of more surveys are we going to do? So this is what we did the last 5 years, and going forward, we are going to do 3 more. This time around, everybody gets a survey. So we're not going to do the stupid age cutoff that we did before. So everybody gets one. Everybody gets to fill one out. They're going to happen about every year and a half the next 5 years. We're going to open enrollment back up. As we saw in the very beginning of this presentation, we have some gaps and we want to fill in our diversity. So for folks with post-polio, we definitely need men. We have way too many women. So if you're a man with post-polio, we need you. And we have flyers in the back, so if you're interested in participating in our survey, just contact us, let us know. We're also going to do this very cool behavioral intervention, and it's called Project Enhance, and it's an award-winning intervention that's being used in older adults right now all across the nation. It happens through senior centers, community centers, assisted living centers, but they don't know whether it would work for people with long-term physical disabilities. So we're going to try it out and see if it works. And with this intervention, you work with a wellness coach. You get to choose a health goal, any health goal you want, and you work towards it with this counselor. It happens over 6 months. So as we've kind of found in our last 5 years of research, we think working towards one health goal of your choice can affect many of those different things that we were talking about. So if somebody chose fatigue, I want to learn how to conserve my energy better, that only wouldn't affect fatigue, but it might also improve your pain, your depression, improve your quality of life, increase your resilience, many things. So this is why we chose Project Enhance to sort of adapt, because it's very individual. So each person gets to choose what they want to work on. You know, we're not choosing for you, saying, oh yeah, you need to do depression, you need to do fatigue, which that's, in rehab medicine, a lot of interventions are like that. It just focuses on one thing, and you don't get to choose what it is. So we're doing this study with this great group, Senior Services in King County. But I want to also mention that this program, Project Enhance, is available all over the nation. There's nothing preventing you from finding it, going to their website, seeing if it's in your community, and signing up. So if you're not in Washington State and can't do our study, it might be in your community already. So we have these wonderful fact sheets that we developed over the last 5 years. They're all on our website. They're all evidence-based, so they're using the current best knowledge available. We know on the internet there's a lot of hokey information out there that's not really good, so that's why we decided to develop these fact sheets. So they're all based on really solid pieces of information. This is a lovely screenshot from our website. So they're all available on our website. Our most popular one is exercise. I have just a few copies in that back table back there of the exercise one, and then sort of how to get the most out of your healthcare visits. And feel free to check these out. You can take them to your doctor and say, hey, I'm having problems with fatigue. This fact sheet says these things, and you can discuss it with them. And during the next 5 years, we're really going to focus on every time we publish a big research article, we're going to write summaries about it. It's going to be linked on our website under our publications tab. And it'll also be on, we kind of have a blog on our website that we update every time we do something new. Like I'll probably blog about this presentation, and Alex and I took pictures earlier that we're going to post on our website. So that's one thing we're very excited that we're doing. So we encourage everybody to stay connected with us on our website. We have a quarterly e-newsletter that I'm sure some of you are already getting that we send out through email, but we're also on Facebook, and you can like us. We're also on Twitter, and I get to tweet about things. So yeah, it's very exciting. So thank you so much. We were so pleased to be able to come here and give this talk, and happy to answer any questions anybody has.
Can you put that website back up?
Yeah.
We would also invite any suggestions, and especially welcome suggestions if you have any, for maybe things we should consider looking at specifically for post-polio.
This one does work.
Yeah, do you want to?
You want to take questions?
Sure, absolutely.
My question was about in these big surveys, your recruitment methods, okay? Because you got people from all over the country, and certainly I'm sure you're aware that there's tremendous recruitment bias, which is probably why you got more women than men in the employment for other reasons. But
Yes.
so tell me a little bit about how you are going about that and what you think you might be able to do to at least minimize some of those effects.
Well, we're very strict, so we're only filling in the gaps when we're opening enrollment back up. Oh, yes, of course, sorry. So this gentleman asked about our survey recruitment methods. How did we find people to participate, these 2,000 people that participated in our survey? And when we started 5 years ago, I wasn't here with this group, but I know they didn't have any special methods. They just took anybody who came, so it was all comers. And as long as you were meeting the age requirements and that you had one of those 4 diagnoses, the MS, the post-polio, the muscular dystrophy, and spinal cord injury, yeah, they just took everybody.
How did you advertise for people, or how did they know about it in Texas compared to Europe and Seattle?
We work through a lot of nonprofit groups that help folks with these 4 conditions. So there's a registry of people with MD that's at Rochester, the University of Rochester. We worked with that group. We have, is it back on? Okay. So we worked with the National MS Society, who has chapters all over the U.S., but we're of course very connected with the one in Seattle. So we have a big MS population in Seattle that we work with. With Post-Polio, we worked with Post-Polio Health International and Joan, and through the newsletter that you guys get. So that's how we found a lot, and we found a couple other support groups for Post-Polio. I think one in California, and there's a couple other nonprofit groups. So we really worked through the community to find folks. So.
You mentioned that you were restricted to age 65 and under in the beginning. Who set that restriction?
So this lovely lady was asking about why in the year 2 and 3 surveys that we had that age restriction to 45 to 65. And I think that's because some of the prior research said that middle age was a time of vulnerability and a lot of secondary conditions, and I think they wanted to focus just on those kind of middle age groups. So, but
Who set your standards?
oh, the leaders of our research, so they make all the decisions. So who are they? Mark Jensen is the principal investigator of our survey. Mark Jensen, so he's a rehab psychologist at the University of Washington, and he still is going to lead the survey this next 5 years. And the overall director of the new RRTC is Ivan Moulton, who is also a rehab psychologist. So we work with a lot of psychologists. Yes, right here.
You didn't report anything about ethnic diversity. You talked about age diversity, and I'm wondering, will there be any attempts, especially as the United States gets more and more ethnically and racially diverse, if that would be part of the future studies?
So this young lady was asking me about we didn't present any information on ethnicity or race of our survey, and whether that was going to be a diversity gap that we're going to fill. Sort of indirectly, we're going to look at trying to get lower socioeconomic status, and we think with that we're going to get a little more ethnic diversity, but we're not going to specifically try to recruit one ethnicity for our survey.
Just report what ethnicity people are in the different categories too.
We know from our survey that in post-polio and in muscular dystrophy and in MS, it's 90% Caucasian. And spinal cord injury, it's 80% Caucasian, and then about 15% African American, and then another percentage of other ethnic groups. For MS, that's more representative of the national population we know. We're not quite sure with the other groups if that's more nationally representative or not. But that is one thing we want. We want to bring more diversity to our survey. Yes, you're right there.
Yes. At one point, at the end of the section, you mentioned that there were strategies for developing resilience.
Yes, so I'm going to just repeat the question, but I'll pass it off to Alex. So what are we going to do with resilience? Are we going to develop an intervention? How are we going to study that further the next 5 years? So Alex?
Yeah, and some of the things that are already kind of known about resilience and how to develop it are that problem solving, for example, problem solving coping skills are important to resilience. Spiritual well-being, so kind of having some spirituality can increase resilience as well. Also, there is kind of this interesting other aspect that includes physical resilience. So by that we just mean that things like physical activity, for example, can not just have an effect on physical well-being, but also your emotional well-being. So we think that maybe those might be some ways to increase resilience, but there really isn't anything out there at this point, intervention-wise, that we can definitively say, yes, increasing some of these things will increase resilience. So there is one particular project that, one study that is part of our new RRTC that looks at an intervention that's specifically geared towards increasing resilience. So we're starting again with focus groups because we're not entirely sure how we should go about this, and getting some feedback from people.
Yeah, so one of our investigators, Dawn Eady, who's another rehabilitation psychologist, she's going to develop an intervention that's resilience. She's much more connected with the MS population, so since it's a very pilot project, she's going to start just with that one group, and then, but if it's successful, we hope to then take it to all groups, anybody that's aging with a long-term physical disability. So, yeah. You right there?
The post-polios do seem to have more resilience. I know I have several friends that throughout the years have developed MS, and they'll say, well, how do you deal with that? Because I was so young, I just said, I never knew any different. I just go on, and they're wondering how can they deal with their disability, accept their disability, and move on.
That's a very good question. So the question was, how high is the resilience in people with post-polio and compared to our other groups? And I'm going to have Alex answer that too.
Yeah, and I am actually really glad that you asked that question because it was something that really intrigued me, in that we did find that people with post-polio had higher resilience on average than some of our other groups. And I have some thoughts as to why this might be happening, but maybe you could let me know your thoughts, and you can feel free to email me as well. I'd be very interested, but maybe it is something about having that early experience, being able to live through something and learning how to deal with it, that you can then draw on at a later point when you come across problems, whether they are similar or different, but you know that this is something that you've dealt with before, you can get through it, kind of being able to see the other side of it. That might help you as you encounter future obstacles. Absolutely. Yes? And so the question was, and I'm assuming you're talking specifically about resilience? Yeah, so looking at kind of the onset, the duration of the disability basically, and how long it's been, and that there are various differences across the different groups. And absolutely, I mean, we did look at how long it's been, and we didn't find a relationship specifically between the duration of disability and resilience. But maybe it is something about the nature of the condition or the disability that could contribute to some of the differences that we do see. So if we think about spinal cord injury, very often that is kind of that sudden traumatic onset that you then cope with. For things like muscular dystrophy or MS, it's typically a progressive, it changes all the time, constantly trying to get readjusted to what is happening. And maybe for people with post-polio, again, I think it has something to do with going through something at a young age and kind of learning to cope with that. You build up that resilience, and then later you can draw on that when you're encountered with symptoms again. But it's an interesting question, absolutely.
Could it be the A personality and B personality?
So the question was, could it be a personality thing? Could it be a type A, type B personality?
It's possible. There was I'm going to quickly plug my supplementary survey that was recently sent out, and maybe some of you filled it out, but I asked specifically about coping skills, for example, that might go or contribute to resilience, and there were some other things that were included, but those are definitely things I look forward to exploring further.
Something else to consider is with polio, for many people, they had it at a young age, but then they had many years of stability before the post-polio syndrome began to have its effect. So those years of stability, we were able to have what many of us term as a normal life. And now we're having problems with the post-polio syndrome. But going back to what you said, having gone through the initial thing at a very young age and developing that resilience to do the best I can do and become the best I can become, I think does help to carry over then when post-polio syndrome begins to have its effects.
Yeah, so talking about like banking that resilience or almost building a big reserve of it during your initial polio episode, and then when you have years of relatively stability, then that gives you this big bank to draw on. Then when you start having post-polio syndrome symptoms.
Yes, and I think one of the next steps for the research, for the studies or the analyses that I plan to do, I would like to look at some of the groups individually, because I think there are some differences that we just can't ignore between the groups. It'll be really interesting to see what we find, and we hope maybe we get to share it with everyone once we do find out.
Yes, we're going to keep sharing our results. It's going to be always on our website, and for those of you who are participants in our survey, we mail out like a survey newsletter, and we'll keep doing that like once a year as well. So, all right, well, we thank you so much for having us here. We've really enjoyed the conference.
Thank you.